Hi, welcome to Med Medicine with Miss P. And I thought today we'd finish where we left off last time and attack the CHF issue again, because apparently it's very, very tricky and impossible to understand. I feel it's pretty simple, but when it comes to heart failure in general or what leads to CHF is kind of the chicken or the egg. Did uncontrolled hypertension begin and eventually cause like cardiomegaly and such force on the heart that it's increased the workload so much so that you've got major left ventricular hypertrophy, and that added lack of care, poor diet, exercise, along with renal failure, led to heart disease, clots, foreign bodies, whatever that maybe there's previous MIs, or were there MIs to start with, or some electrical issue that created heart failure and then it kind of proceeded into the rest. So generally most of uncontrolled hypertension will eventually cause kidney damage. Maybe there was kidney failure to begin with, and that superseded the whole situation. But at any rate, this is what I get all the time. And because for almost 15 years, I studied it really well. And not that I quit after that, but, being in the hospitals and long-term care facilities, so diligently paying attention to these people's lab values, their H&Ps, and reading through it very consistently, you really learn a lot, especially if you attempt to pay attention. And I really did. I probably started out pretty naive, and then the more I started paying attention, you kind of become Sherlock Holmes. It's not that tricky, but when you see it over and over and over and over, you put two and two together, and you start to get this very easy picture to understand. So anytime, and I know my students have heard me say this only 400 or 500 times, when I see metoprolol, lisinopril, carvedilol, Lasix, and isorsabide or something like that, I already know they have CHF. That is the CHF cocktail. You're going to see it over and over. It's going to vary a little bit, but as soon as I see carvedilol and a diuretic, that equals CHF. And then surely there's something else in there, maybe some digoxin, which makes me think kind of AFib may have started the whole situation. Maybe there's an ACE inhibitor or an ARB, that's, or even a calcium channel blocker. You see cardizem, carvedilol, and Lasix. You have CHF. You can deny it all you want, but that's what you got. So I'm talking to this lady on the phone, and she gives me her cocktail. I already know she has CHF. And then she said, yeah, I had some fluid buildup. I said, in your lungs? And she's like, yeah. Yeah. So, and of course she denied CHF when I asked her, but she takes Lasix every day, 40 milligrams. So we already know what happened, right? So you retain all this fluid so much so that it's got no place to go. And then it finds the path of least resistance, and it ends up, you end up with this massive pleural effusion. So, kind of starts with hypertension. That fluid is inside your vasculature. And then when that's kind of not maxed out, but overloaded, it finds its way to seep into your tissues. And because your vasculature and your aldosterone, your kidney, the whole situation, the whole system isn't working correctly. So that fluid kind of ends up in your feet. And then everyone's like, no, it's not my kidneys. Okay, well then when you come into the hospital with fluid buildup, we don't give you digoxin. We don't give you a big dose of cardizem. We don't give you a big dose of propranolol. You get a diuretic. You get a loop diuretic. That's because the problem is in your kidneys. You don't have to like it. You don't have to agree with me, but I promise you that's what it is. And anytime any student or even a coworker or a colleague, and anytime someone's brought this to me, I can always trace it back to exactly where it started. And it's very simple, and it's very common sense as far as I'm concerned. There's plenty of things in medicine I don't get, and I have to ask questions all the time, but this to me is a very obvious situation. So, yeah, and then ironically, after this lady is denying CHF, and the doctors don't tell them, and there's like no point in telling them, because whether they think they have it or not, they have a heart condition, that they have cardiovascular disease, they have uncontrolled hypertension, and they have kidney failure. That's CHF. At any rate, so I talked to 3 other patients after that, and they were all the exact same, crazy, same cocktail, same situation. It was really, really wild. But as soon as you have a pleural effusion, that is kind of a given that is not your first CHF exacerbation. You don't just go straight to this some massive pleural effusion. I think it may have been the same lady. It could have been a different one. Usually I put a line in between the patients. Under surgery, she said that she had a bladder probe. You think that was from aliens? You think aliens are probing her bladder? She had a bladder probe. Precious. I put that in as a cystoscopy, because I don't know that they probe your bladder as much as they look into it and try to find out whatever the situation is, whether you're having a biopsy or if they're going up through it to do a uroscopy or get a stone or whatever it is. Another lady said that her last, and I'm sure this was a typo, but it was still fun. Her last menstrual period was in 1917, but she's only 65, so do the math there. And she had a C5 fusion under local. I keep telling you, they need to just take that out of there. Hysterectomy, a right total knee replacement, and tonsils, all under local. That is a big savings in anesthesia fees right there, I'll tell you what. Emergency. Oh, yes. And I get this once in a while. When a patient puts down their emergency contact as themselves. So if you are currently having a medical crisis and an emergency, you want us to tell you? I would like to think you were the first to know, but you want us to tell you again? There's nobody else in your entire life you want us to make aware? You're the emergency contact? Now, come on. That's not a medical thing. That's a lack of common sense thing. That freaks me out. Oh yeah. We always ask, what's Dr. So-and-so doing for you on Tuesday? And this one says, I'm just gonna fix my pupil. That's a hole. You can't fix a hole any more than we can remove a hernia, or all the people with the what they insist was a vagina hat, even though they were wearing, like, I guess labia or something, because a vagina is a canal. You can't, unless you had like a pink paper towel holder or a toilet paper roll on your head that was empty and painted it pink. Like, that's a vagina. It's a canal. We can't fix your pupil. It's a hole. Fix it. They had a retinal detachment, by the way. We'll go through the pupil to fix a retinal detachment, but we can't fix your hole. Another one said, oh, yes, the surgery, under surgery. They put removal of infection. I don't, where on the body? How is an infection removed? Maybe it was like an IND. You can't make this up. Oh, and then also they had a hernia removal, which is right next to, my original. Can't remove a hole or a tear. We can repair it, but we can't remove it. Oh man, does my favorite pen not work? That's a pen that looks like wood, and I guess that's trash. Okay. Oh, and this young girl, she wasn't dumb. I just don't know where she was going with this. Under surgeries, and she had a lot of them. She wrote orthopedic right knee. That was her surgery. Orthopedic right knee. Now, all of your joints and bones are going to be an orthopedic thing, but I don't know what an orthopedic right knee is. I'm assuming she meant arthroscopic right knee meniscus repair or something, but she wrote that like 3 or 4 times. And then one gentleman put in here that he had a number 12 backbone. That's what it said. If we ask you to fill these things out and you don't have any idea what you're writing, surely you recognize that you're going to be on the phone with us for a while as we try to decipher all of this stuff, because it doesn't make any sense. The things you guys write, it makes no sense. Oh, and this one that typed in, there's like certain boxes you can fill in from time to time depending on what the situation is. And they wrote in that, I haven't had reflux since my heart attack. Woo! Thank God that heart attack fixed that whole reflux thing. Kind of neat how they work together that way. I left it in there because I don't feel I'm the only one that should enjoy that sentence. Haven't had any reflux since my heart attack. So what you're saying is all the little heart attacks you had you thought were reflux. And then you finally had the big heart attack and now you don't have reflux anymore because they were probably little mini heart attacks. I don't know. Oh, this one guy, whoa, God, this guy was so much that even when the surgeon, after he came in for surgery, I happened to be at the desk and the surgeon comes out, he's like, man, oh my God, that guy can talk. I'm like, he talks faster than I do. I don't even understand what he's saying. It's like he's on speed. And he also charted that he had 10 drinks a week. It's like 2 every night and then none on the weekends, I guess. I don't know, or maybe he has 5 Friday night, 5 Saturday night, but he was so, and I couldn't even follow what he was saying. And it was so difficult that I just kind of, I just moved on. There was only so much you can fix. But he said, he wrote down in the whole COVID thing that he gets short of breath, but it's only on the right side. I don't know how you get short of breath on the right side. And he was talking so fast. I can only assume that he had some cocaine that morning because nothing else he said makes sense. He also said, but that's to be expected because the thing he's removing is on the right side of my neck. That that's still that I don't understand what that was. He also had 26 years old. He had a left bundle branch block on his EKG, but he has nothing wrong with his heart. His heart's fine. No, there's a chance you could have had a mild little MI there. He's like, no, I'm totally fine. Yeah, the doctor said so. That's because the doctor thinks you're too stupid to understand what a left bundle branch block means, and it doesn't necessarily 100% indicative of a previous MI. But if there's a loss of electricity to that area and that tissue is dead, something had to have killed it. So that's there are other freak reasons, but I'm thinking all the cocaine he takes has something to do with it. We'll see. I'm pretty sure he did fine in surgery, so maybe he didn't have coke the day of surgery. Um, yes, there's another one who made his emergency contact himself, and then this says that oh yes, this other guy he was sweet. He ended up coming. His wife was really cool, but he came in and I asked him on the phone, so he's going to drive you home. He's going, well, I'm going to have to drive myself home. I said, sir, you're having a general anesthetic. He's like, yeah, I know, I'll be fine. I said, no, it's illegal. You can't drive home after general anesthesia. It's literally a DUI. And he's like, oh, really? Yeah, we're going to put you to sleep so much that we're going to cut into you, open things up, mess around with the insides, and close you back up. Do you think that's not equivalent to at least a couple beers? If you can't drive home after 3 or 4 beers, you can't drive home after general anesthesia. Either people think it's nothing or they think they're like it wiped them out for a whole week. Like, well, then you should see a specialist because something's wrong with your liver because this anesthesia's gone in like 18 hours, 16 hours, maybe 24 hours. So if you're all knocked out for the whole week, you have liver failure and your liver's not processing and excreting this, or there's something else wrong with you, or you just really need attention. I don't know. Also, all of his meds were spelled so wrong that I couldn't even figure out what they were. And the thing is, like, as you're typing it, now I don't know what it looks like on the other side, but as a nurse putting the information in, as I'm typing it, it'll give you a whole bunch of options. And then if you change one letter, it'll give you other options. And then if you change another letter, it'll give you no options because you're spelling things wrong. And he just put in all kinds of ridiculous things. I could not even figure it out. But he ended up coming in. His wife came in to drive him home. They were cute. Everything was fine. Oh, another one is charted that he had prostate cancer, but do you have problems with your prostate? He said no. If prostate cancer is not a reason or a problem with your prostate, what would be a problem with your prostate if cancer doesn't qualify? Surgery, mastoid, that's all they put. They put mastoid under surgery, and then another surgery she wrote down, this was an elderly lady, she wrote down exploratory. That's it. They just explored her whole body for a surgery. Exploratory. Yes, and then here is another one that's, yes, now this is the opposite. Mostly I get the other way around, but the patient said that after the CVA, they were having heart problems. I said, no, that was a fluke. There's no CVA that could affect your heart. I mean, I don't think so. Maybe if you had like a cervical stroke, that the nerves that innervate your heart, but if it is straight up a cerebral vascular accident, maybe a cervical vascular accident, but that's and nobody understands how strokes and heart attacks are not related, like at all. They're completely different organs, any more than if you had like a loss of blood flow to your liver, that it would affect your kidney. They're not. That's not how that works at all. But it's stunning how many people think that it's the same thing. Also, here's a question which I can't figure out. Whenever I have a patient lie back in bed, we've finished their vital signs, they signed all their papers, I got all their questions answered, then I say, go ahead and hop in bed, I'll maybe put their SCDs on or something. They lie down and then they like hold their head up with their hands like this. And I'm like, there's a pillow on the bed and it's not attached to the bed. It's not like a Barbie pillow that's on the Barbie bed where it's like sewn in place so it looks like that. You could move it, and I always have to pull the pillow out from underneath their shoulders, fold it in half and put it under their head, and they're like, oh, thank you so much. Do you all know how to work your own pillow? Like at home, if you're lying in bed and your pillow is uncomfortable, like you know you can move it for your own comfort, right? Because I don't, and it's not once or twice. It happens all the time, like all the time. They're holding their head up, or they're like sitting up, kind of like this, and I'm thinking, see that pillow that's under your shoulders? You pull that up to back to the head of the bed where it once was before you jumped in bed like an animal and made it fall down. Like put it where it belongs, and then support your head and neck to where it's comfortable for you. And they're like astonished when I do it for them. Like they don't, like they're unaware that they can move their own pillow. I don't care where I am. I'm gonna get comfortable no matter what. It happens a lot. Like I don't understand that. Okay, and then here's the last one. And I'm sure when he comes in, I'm sure I'll hear something about it. This guy says he's allergic to nitro because it drops his blood pressure. Yeah, that's what nitro does. It's a vasodilator. It literally drops your blood pressure. Now, it shouldn't be super significant, or you might be getting too much. And I'm not saying we're going to give you sublingual, but if you begin to have chest pain, and on the EKG we see a STEMI, we're going to immediately put some nitro at least on your chest. And you don't have to have a full inch or 2 inches or anything like that. We can give you a smidgen, but I'm pretty sure that that's what people would do, whether you're in the ambulance or wherever. I think the whole like dropping your blood pressure versus saving your myocardium, I think that one is a little more important than the other. Not to say that we couldn't give you something to increase your blood pressure back, but he was like adamant. And I think he even said something like his daughter was a nurse, so I'm sure she's going to have, if he goes back and says, the nurse told me that they're going to give it to me anyway. That's, of course, not what I said, but what I explained is that I would not go around telling people you're allergic to nitro. Oh, and by the way, he has 5 stents, clearly coronary artery disease, and a couple other issues. You should still have nitro with you, even if it's not 0.4, some paste or something. It is worth the risk of your blood pressure bottoming out to open up the vessels in your heart and to try to save you. And he said, no, doctor says aspirin's the only thing that's going to save me. Yeah, aspirin isn't, it doesn't lyse, it's not a lytic. It doesn't destroy the already made clot. That's not how that works at all. It can decrease the size of the clot by platelet aggregation, and even the thought that aspirin is going to immediately get like to the particular platelets in your heart and in your your coronary arteries. I mean, not to say that we wouldn't give it, but I don't believe that aspirin would save your life. I just talked to a doctor not too long ago that he said even an aspirin a day is not proven to significantly decrease the risk of myocardial infarctions. And of course, that's all we need to know. So y'all wear your ribbon so you know how you're going to die. Don't change your lifestyle or your meds, or change your meds, or get on something all natural and try to find out how to help yourself. But wear your red ribbon so we're all well aware of how you died. All right, that's it. That was longer than I expected. I didn't even have much info, but you know how I tend to rattle. So there you go. Okay, see you soon. Face your fears, forget your failures, follow your faith.